Good afternoon, everyone, and welcome to today's webinar hosted by Region 10 chapters of HFMA. The topic for today's webinar is the Washington Healthcare Policy Update. I'd like to welcome today's guest presenter, Julius Hobson, Jr. Mr. Hobson is with Polsinelli PC and strives to meet client public policy goals and objectives based upon the client needs and capabilities. Julius has more than 40 years experience in public policy, working both inside and outside government. He has a deep-rooted understanding and compassion about the public policy process, both legislative and administrative. He primarily serves healthcare clients with particular emphasis on physicians, hospitals, home health, and long-term care providers. So, without further delay, I'll hand the call over to today's guest presenter. Julius, please go ahead.
Thank you, Nikki, and good afternoon there to everyone. Going to start with what we look like in Washington at the Capitol in terms of Congress. We have 233 Democrats, 197 Republicans, 1 independent, and 4 vacancies. You may have heard that Congressman Van Drew of New Jersey is going to switch his affiliation from Democrat to Republican. He did vote no on impeachment twice last night, but as of this morning has yet to confirm that he has changed his registration. The Senate is 53 Republicans with 45 Democrats and 2 independents. One of the things we always do in terms of advocacy and with regard to health care is looking at how many professionals, how many members of Congress, both in the House and the Senate, were trained as healthcare professionals. And this is what it looks like now with 3 physicians in the Senate, 1 optometrist. We've got physicians and dentists, and yes, we do look at veterinarians in the same light, psychologists, nurses, a pharmacist, and a physician assistant. Oftentimes on healthcare, members of both parties will consult with healthcare professionals not only about their personal healthcare issues, but in terms of policy issues and how a particular piece of legislation may impact the delivery of healthcare. The leadership is fairly stable in both places. Nancy Pelosi is the Speaker, Hoyer is the Majority Leader, Clyburn as the whip. The Assistant Speaker is Ben Ray Lujan, but he is retiring because he is running for open Senate seat in New Mexico. Hakeem Jeffries is the caucus chair, new in this Congress. Sherry Bustos chairs the campaign committee. On the minority side, there's virtually no change there with Kevin McCarthy as the leader. Steve Scalise of Louisiana is the whip. Conference chair is Liz Cheney. Policy chair is Palmer of Alabama, and the campaign committee chair is Emmer of Minnesota. The Senate leadership, on the Senate side, we did have a change from the last Congress to this. Outside of the leader, Republicans term limit their leadership. So John Cornyn stepped aside as whip, and Thune is the new whip for Republicans. Barrasso of Wyoming is the conference chair. Policy chair is Blunt. The vice chair is Joni Ernst of Iowa, who's also up for re-election next year. Young of Indiana chairs the campaign committee. On the Democratic side, there's been no change in their leadership with the exception of Masto of Nevada chairing their campaign committee. Both parties entered this Congress with their own set of priorities. Some of these things I will come back to on a few slides away from here. But as you can see on both sides, there are some things that are similar. Prescription drug prices. Both wanted to deal with the Affordable Care Act, although not in the same way. Surprise medical bills is still something that's hot. The prescription drug prices and surprise medical bills being at the top of the list. Democrats want to do a lot more oversight. Democrats also had some discussion about Medicare for all, though I will say flat out there are insufficient votes for Medicare for all. In fact, most Democrats are not even on board on that one. Immigration is an issue. Vaping has become an issue for both parties. One of the interesting things about this kind of work is that issues will pop up that were not on the radar screen. Earlier this year, vaping was not an issue, but as that has become a problem, then it has managed to make the list. On the Republican side, clearly they want to deal with changes in the 340B discount drug program. The Republicans have tended with regard to prescription drug prices to look at the pharmacy benefit managers and say that they're the ones who are the key problems with regard to increase of drug prices. The House has just passed their drug pricing bill. They named it after the late Elijah Cummings of Maryland. This is something where they would allow the HHS secretary to negotiate drug prices. Currently, there's a provision in the statute that explicitly prevents the HHS secretary from negotiating drug prices. They would use the reference of what is considered to be the developing countries: Australia, Canada, France, Germany, Japan, and the United Kingdom. The idea being that the secretary could negotiate better prices down the road. This was a rather the issue. There were a number of issues that were contentious just amongst Democrats, but they did succeed in coming together with some unity to get this bill passed in the House. As you can see, they would limit the annual price increases for drugs that are covered by Medicare Part B and Part D to a rate of inflation, and they're using the CPIU as the measuring stick, which is a pretty good measuring piece with regard to inflation. They're trying to place limits on drug manufacturers and what they would charge. They also would add some benefits for dental, vision, and hearing care to the Medicare program. This has been a big discussion with regard to expanding Medicare for some time, especially with regard to the dental aspects, as there has been a greater understanding of how dental health can affect the overall health. The Senate has not passed a bill yet. Now we're in an interesting situation here where you have the House bill was partisan. That vote was partisan. In the Senate, we have a proposed bipartisan provision from Senator Charles Grassley, of Iowa, who chairs the Finance Committee, and Ron Wyden of Oregon, who is the ranking member. And they would seek to reduce the cost of drugs. Now, the problem in the Senate has been that Majority Leader Mitch McConnell has been dealing with judicial nominations. There's a lot less legislation that's been up on the floor, but he has blocked this issue from coming to the floor in the Senate. And in the last couple of days, Senator Grassley came out in public and blamed the Majority Leader for not being able to get something done, and said that he was going to try to do this, Majority Leader notwithstanding. Those of us who have been in this for a while are more than a little bit surprised about that, since it's a little difficult to move something on the floor of the Senate unless the Majority Leader goes along. But clearly this issue of drug pricing will not be dealt with this year, so it's more likely to come up again next year. As you can see, require Part D plans and their pharmacy benefit managers to include concessions and fees that they negotiate with a pharmacy. Again, the idea that the pharmacy benefit managers are a part of the problem. Large agreement on that, both amongst Democrats and Republicans. With regard to surprise medical billing, this was another issue that I had thought might have a chance of being dealt with this year. The House Energy and Commerce Committee reported its own bill. The Senate Health, Education, Labor, and Pensions Committee reported its bill. The Senate bill would set a benchmark. On the House side, in the Energy and Commerce Committee, the original bill set a benchmark of $1,250. Any bill that exceeded that amount would then go to arbitration or independent dispute resolution. What happened is that Democrats and Republicans on the Energy and Commerce Committee in the House and Senate Health Committee Republicans came together on a compromise, and they set a benchmark of $750, and then you'd go to the independent dispute resolution after that. But the ranking member on the Senate Health Committee did not agree with this compromise, and so she has withheld her support, and that's Patty Murray of Washington. In addition, Democratic leader Schumer has also not signed on, so it's not clear what can move in the Senate. The $750 threshold will be interesting. When the Senate Health Committee first did its bill, the Congressional Budget Office, which is charged by law for providing cost estimates for bills, for legislation, estimated that you save a significant amount of money when you go to a benchmark as opposed to independent dispute resolution. And especially if you peg it to area geographic economics. And that would have, the difference in the Senate bill was a savings of $20 billion. So we have no CBO score on this one as of yet. Big concern is letting patients pay in-network prices for any out-of-network facilities. This one also has a provision dealing with surprise billing with regard to air ambulances. There's also the issue of timely bills for patients. I know how that can be. In the case of my late mother, we would get ambulance bills 6 months afterwards, and we're trying to figure out, when that occurred. So the timeliness of bills really matters. The White House issued a statement in support of this compromise, but in the meantime, the House Ways and Means Committee, Democrats and Republicans, came out with a proposal of their own. What you see there is all we know. We have no other details other than these top lines that they put in there out in a one-page statement. So we have to see where that goes. Bottom line on surprise medical billing, however, is that there'll be nothing on this issue until next year. Switching now to the budget, last summer we got a budget agreement on the overall top lines for the budget before they crosswalk those provisions into appropriations bills. But that had taken some time to achieve. But between that time and a couple of weeks ago, we had issues with trying to agree to the specifics on the 12 appropriations bills, which is now being dealt with. But as you can see, again, the top lines are defense spending and non-defense spending for the next couple of fiscal years, and also to deal with some issues with regard to the 2020 census to make sure that is sufficiently funded. And as a result of budget agreements in 2011 and 2012, we do have a provision in the statute for cross-the-board cuts. This postpones that sequester for an additional 2 years, so we probably are 10 years out before we would see one. They managed to reach a compromise on those, in what we call crosswalking, also known as 302B allocations, from those top line numbers to the 12 appropriations bills. The House has 2 days ago passed their bill. As of about 45 minutes ago, or maybe an hour, the Senate passed one of the 2 appropriations bills. They took the 12 and divided them into 2. There is an expectation that they will pass the second bill sometime today, after they deal with some judicial nominations. So what we have, though, is a substantial increase in spending with regard to health care, a $2.6 billion increase for NIH, the $328 million increase for mental health. Community health centers got good funding, so did rural health care, an increase for children's hospitals, medical education. What I want to point out of particular importance is the bottom, the Centers for Disease Control, $25 million to do research on gun violence. Heretofore, that has not been possible. This is an opportunity to get more data on this particular issue, as well as the healthcare ramifications, and also the additional money with regard to opioid overdose and surveillance prevention. For particular healthcare issues, the Medicaid DSH cuts that were expected to go into effect by statute have been postponed temporarily until May 23rd of next year. We have a list of health extenders, the three that stand out: community health centers, National Health Service Corps, Teaching Health Center Graduate Medical Education Program, are all extended to May 22nd. All of the rationale behind these is the assumption that somehow or another Congress will deal with drug pricing legislation, and there will be enough savings from the drug pricing legislation to offset increased expenditures for these programs. It's not clear, however, that they will be able to reach an agreement on drug pricing by that time. There are other provisions in here, particularly the allowing generic drug developers to bring civil suits with regard to drug manufacturers. This incorporates what was called the CREATES Act that was in both the House and the Senate. There is an expectation that this will help save some money down the road. They also increased the minimum age to purchase tobacco from 18 to 21. This also includes access to vaping. As I'm sure many of you are aware, a lot of the vaping issues with regard to healthcare have impacted young people, and particularly young folks who are in as young as junior high school or middle school and high school. PCORI was extended for another 10 years. When the Affordable Care Act was enacted, it had a sunset provision. Now it's going to go a little bit longer and extend some fees for health insurers, and self-insured health plans was also included in this. One of the interesting features about this appropriations bill is the fact that appropriators don't particularly like authorization legislation attached to spending bills, but this bill is actually both of them are full of these kinds of provisions. The other thing that it does is that which was a bit of a surprise, because as of a week ago, a little over a week ago, the thought that Congress would deal with some of these Affordable Care Act taxes did not look promising. But in fact, in the end, over last weekend, they came together, and so the appropriations bill includes a repeal of the Cadillac tax on high-cost employer health plans, which was scheduled to go into effect in 2022. The 2.3% medical device tax has now been permanently repealed, and the annual fee imposed on health insurance providers. All three of these are now permanently repealed. The other thing is to a provision that would require the Department of Health and Human Services to establish an automatic re-enrollment for individuals who purchase insurance through the Affordable Care Act, and they have to do this by the time of the 2021 pay year. This is a manner in which those people who sign up for these plans don't have to go back and sign up every year, and that will probably save some money. It's just a question of HHS developing the computer software to be able to make this happen. There's another provision with regard to taxes, the administration and the silver loading, in which insurers raise premiums on the mid-tier folks in order to give tax breaks to those who are pursuing cheaper plans. The one thing that appropriations bill did was to add significantly to overall spending. The whole appropriations, both bills, comes to $1.4 trillion in spending in fiscal year 2020. The Congressional Budget Office has estimated that we will exceed $1 trillion deficit in the current fiscal year. The administration also agrees with that. There is nothing that, no daylight between Congress and administration in terms of those budget projections. Obviously, some disagreement on the why, but the deficit will continue to grow. The debt will continue to grow, at least in the foreseeable future. There has been some decline in revenues in 2018, which were attributed to the 2017 tax law. There have been some reports that have come out just in the last week about 91 corporations paying no taxes, many others paying less, and a lot paying at a lower rate. But given the current makeup of Congress, I don't see any changes in tax law. With the aging of with the population's aging, and that's we baby boomers starting to collect Social Security and signing up for Medicare, that will end up increasing expenditures for Medicare for some time. So that's something we can look for. In the administration, this is one of the few times that I have managed to present this slide and not have to say there's some new, there may be some other changes or something different for the moment, and I'll address one of those now. But these are the key departments and agencies that we look to with regard to healthcare policy. In particular, I want to point out within the Office of Management and Budget is the Office of Information and Regulatory Affairs. Whenever an agency or department prepares proposed regulations on any subject matter, they must go to this office for review prior to printing in the Federal Register. Paul Ray is the acting head of that office. He has been nominated for the permanent position. His nomination has made it out of committee, but there are some other issues. I expect probably next year he may well be confirmed. I'm not thinking that he will get confirmed this week. This office also, once they sign off on proposed regulations, they're published in the Federal Register. Then they go through the comment period. When the department or agency prepares the final regulations for publication in the Federal Register, they must be resubmitted to this Office of Information and Regulatory Affairs. They have a dashboard, and we all watch that on a daily basis. That dashboard tells you when the proposed or final regulations were submitted. They're committed to a 60-day review period, so you can pretty much figure, you check it out every day. When it disappears from that website, then you can expect that they'll be published in the Federal Register probably within the next 3 days. With regard to Health Resources and Services Administration, HRSA, Ingalls is now the permanent head there. Some of you may have read about a feud between HHS Secretary Azar and CMS Administrator Verma. They were called over to the White House last week, about a week ago, to try to smooth over whatever that feud is about. I cannot tell you what the outcome is going to be, but historically on issues like this, when this occurs, one of three things can happen. One is they resolve whatever their differences are. Two, one of them gets fired. Three, both get fired. I can't tell you which way that's going to go. Many of us hope that whatever their differences are, they can be ironed out. The other is you don't always know how much of this is between the two principals and how much of it may be their staff. We don't know any of that at the moment. It's just hopeful that somehow or another they work that out. Going down the list, Eugene Scalia is the newer Secretary of Labor. Pretty much everything else is constant. Whenever presidents want to make policy outside of dealing with Congress, they have a number of options. They can use executive orders, and we've been living more and more in a world of divided government between the president and the Congress, with one party controlling one branch and the other party controlling the other, or in the case of Congress, one party controlling, as we have now, Democrats controlling the House and Republicans controlling the Senate. So presidents use executive orders to set policy as a means of getting things done as they see fit. This process of using executive orders sort of picked up a little bit during the Clinton administration, picked up steam during the George W. Bush administration, and during the Barack Obama administration basically stepped on the gas. This administration, to use the Star Trek term, is gone at warp speed in terms of executive orders. Everyone hears about executive orders, but the second part of that is oftentimes there's a presidential memoranda that goes to the departments and agencies in basically instructing them in terms of how to carry out the executive order. Presidents can also use proposed and final rules to make changes in policy. I'm going to come to that in a minute. Regulatory guidance notices are also out there. The change, for example, I'll talk about shortly in FDA with regard to importation of prescription drugs from Canada. There's actually a regulatory guidance notice. Then there are interpretive rules where an administration can talk about slight changes in how they're interpreting regulations and laws. Obviously, presidential policy decisions, as well as presidential nominations. This administration has put out a number of rules. We've got one that's out now that deals with hospital transparency and publishing information on prices before discounts that hospitals negotiate with insurance companies. This one is being challenged by the various hospital associations in the courts. They literally have just filed suit on that. In essence, the hospital's charge master and what they're negotiating would have to be posted on a website in a format that patients can understand. There's some concern, obviously some concern about this amongst hospitals. How this affects individual hospitals depends on where they are. In some instances, there may be a hospital system that's the dominant one within a geographical area. Then there may be other places like here in Washington, D.C., where you've got competition amongst various hospital systems and hospitals. But you would, in effect, expose all of them to whatever they've negotiated, which is part of the reason why they've pushed back on this. The administration has also sought to deal with site-neutral payments. These are the payments where hospitals were being paid for their off-campus facilities at an in-hospital payment rate. The administration has sought through regulations to change that, to say that in outpatient facilities, hospitals would be paid at an outpatient rate, the physician rate, and they have sued on that. But we've got a new court decision on that one in which the hospitals lost, but we expect that to be appealed. The other one is using the hospital payment rules as a means to try to cut reimbursements under the 340B drug discount program. We have an interesting situation here where the hospitals actually won with regard to the 2019 rules, but then the administration in its 2020 proposed rules went right back to this, and the justification was that the court's ruling only dealt with 2019. We'll see whether or not the judge is happy about that perspective, but that's, we'll see how that goes forward. We also have a proposed rule with regard to Medicaid fiscal accountability, and what this is couched in terms of trying to get a handle on spending for Medicaid and the manner in which states adjust their tax structures or payment structures in order to maximize what they get in Medicaid from the federal government, especially with regard to intergovernmental transfers. What this rule does is basically force states to use taxed revenue in order to support Medicaid. One of the problems with this is that the comment period closes next month, and it wouldn't be long before a final rule comes out. But the question is that the final rule could come out before state legislatures would have an opportunity to address this issue. So there is some effort to try to get the administration to extend the comment period for this for another 60 days. We'll see how that comes out. I'm not hopeful that will happen. They'd also make some changes with regard to the Medicaid disproportionate share hospital dish payment, which would in effect harm a lot of hospitals should any of this go into effect. And as always, with all of these proposed rules, I would anticipate them to be challenged in the courts. One of the problems that we have, and when I talked about what presidents do in terms of policy with regard to proposed and final rules and other decisions, is that more and more healthcare decisions are being pushed to the courts, and we've got judges now who are making decisions, public policy decisions with regard to healthcare, clearly in an area which they may not necessarily have sufficient expertise. But as long as Congress fails to write clear and concise laws and delegates less to the executive branch, we're going to see more of that. We've also got some proposed rules that there's a lot of unity and support of, and that's making some changes with regard to STARK and impact and anti-kickback rules. A driver in all of this is technology and how that has changed the delivery of health care. So there's a lot of unity in this proposal, and I anticipate that it will go forward without a lot of problems. Just this week, the Food and Drug Administration announced a draft guidance with regard to purchase of prescription drugs, including biological products from Canada. This is a rather complicated guidance, however, and there is some estimate that it could be 2 years or more before states would be able to make these purchases in Canada. That's sort of, you might say, the good news. The other news is that Canada is very, very nervous about this and is afraid that if the U.S. starts to try to import drugs from Canada, that there will be insufficient drugs for Canadian citizens. So even though states may have this thought, may ultimately be able to do this and carry it out within the law, they may be limited in terms of what they can acquire from Canada. The rule doesn't seem to, the proposed guidance doesn't seem to address that part of it. But the Canadian government has looked at this, and they are very much concerned about Americans coming to Canada to purchase drugs. Going to the Federal Reserve Board, a few years ago I didn't have a slide like this, but I think it's much more important now, especially with regard to interest rates. As hospitals and other healthcare facilities decide to expand or make some other changes to their physical plants, then they tend to borrow money, either from financial institutions or more likely go to the bond market. So interest rate increases or decreases are fairly important. Our inflation rate has stayed under the 2% target. Unemployment has also dropped. So the Fed has stopped raising interest rates probably for this calendar year, and don't foresee raising interest rates, for at least a few more months. The president has pushed them. He wants the interest rates to go to zero, and has hinted from time to time he'd like to fire the Fed chairman, which by law he cannot do without cause. We're also looking at the impact of the trade war. Though we now have Congress is now, the House is today voting on the U.S., Mexico, Canada trade agreement. The Senate will take it up next year. That's one piece. We've got the first round of an agreement in trade issues with China, but the previous tariffs that the administration put in place are staying in place. With regard to health care, where that matters is that they have what's known as the entity list, and that fourth entity list had surgical gloves, caps, and gowns on it. That would have been a substantial increase in tariffs on that, and that would have impacted healthcare providers substantially. There are other issues. One of the things I always say to my students is that no matter what your issues are or how important they may be, there are other things that are going on that may impact what you're doing. Clearly, presidential investigations, Russia-Ukraine issue. I'm sure you're all aware of the House impeaching the president last night. We have word now from the Speaker of the House that they are not going to transmit the impeachment resolution to the Senate before the end of the year. And what we would anticipate is that once the Senate gets that and it starts an impeachment trial, that they will probably come in 5 or 6 days a week at 1 o'clock in the afternoon. And an impeachment trial, how long that will last is not clear. What has happened in the past in the case of the impeachment of then President Clinton, and when I worked in the Senate, I sat through impeachment trials for two judges. The majority leader and the minority leader consult with each other, and they come to an agreement on a resolution which sets the guardrails for how they'll conduct the trial. That negotiation this time around unusually has been done in public, which is not a way to work things out. So we're not clear how that's going to go. That's one of the reasons why the Speaker is holding back on the impeachment resolution to try to give Minority Leader Schumer some leverage. He wants to call witnesses. In terms of how this affects public policy next year, because they come in at 1, they can still conduct other business up until that time. As I said, having sat through an impeachment, I can tell you once the trial starts, all senators have to be in the Senate at their desk. What we like about in Washington is they can't talk, but everything else shuts down. So every afternoon that they're in an impeachment trial, that's going to be going on. The other irony is that we may well be in the middle of an impeachment trial when the president goes to the Hill to deliver his State of the Union address. Infrastructure reform is just not going to happen. It has a $1 trillion cost. The trade issues are still not done. The new word with the issue with China is they'll probably sign something in January. The president just imposed new tariffs on steel with Argentina and Brazil. Another issue to watch is the increase in farm bankruptcies. The last number I saw was they were up by 10%. Immigration continues to be an issue, and as you can see, all of these others, plus the 2020 presidential campaign. What does that mean for healthcare next year? Well, we know that surprise medical billing will be up next year, as will drug pricing, and whether or not Congress can come to some agreement and within the Congress, and then some kind of agreement with the administration. Those are probably the two biggest healthcare issues next year, to see if they can resolve that, plus those health extenders that I talked about that have an expiration date in May. And then there's what I always call the unknown, and these are things that can happen that no one anticipates that may impact public policy. And that's what I have for now. I will stop here and push it back to Nikki for any questions that you might have.
Great. Thank you so much for that, Julius. Very timely, in fact, hot off the press presentation. Before we began, Julius and I were just talking about how he was, really making some last minute updates to his slides, so you guys will get the latest and the greatest. So we're really appreciative for you doing that. All right, so before I take our first question, just want to remind everyone, type their questions into that questions chat panel located to the right of your screen. And we'll take as many as time will allow. For those of you who are wondering about the slides, so if you join late, you don't have to worry about waiting on those. You can gain access by expanding the handout section, also located to the right of your screen, and clicking on that little PDF icon. All right, so let's jump right in with our first question for you, Julius. Can you speak to the requirements for provider compliance related to the price transparency rule? I think we touched on that a bit.
What I would anticipate with the transparency is that providers will probably be stuck with additional paperwork for reporting requirements, and that's going to take up more time for all the providers, and I do mean all. So it'll be physicians, anyone that gets reimbursed directly under Medicare. So you have physicians, nurse practitioners, probably nurse anesthetists, social workers. There's simply just going to be another addition to the paperwork, and trying to be careful about what they write down to make sure they get it correct. Otherwise, you obviously will have IG issues down the road, and maybe reimbursing the federal government later on. This will be a particular problem for individual practitioners as well as small group practices. I would anticipate over the long run that we will continue to see consolidation amongst providers, and there'll be fewer and fewer individuals practicing by themselves. The American Medical Association recently came out with data that shows the majority of physicians are now employees. This is one of the reasons for that. I speak in a number of programs where there are physicians and other healthcare providers who are basically going back to school in executive MBA programs because medical school didn't teach them how to run a business, and this is going to be a part of that. Nikki?
Great, thank you so much for that. And our next question is, can you share more insight about the Medicare Advantage plan expansion that has been occurring? What's driving this?
I'd say what's driving it is prices. Actually, I can speak in personal terms, as I've obviously beyond the Medicare age limit. So I actually sat through an hour-and-a-half presentation with Kaiser Permanente just to see what that looked like, and its costs. What you worry about is the cost of prescription drugs. Will my healthcare costs over time exceed my income? So you start to look at different ways where you can reduce what you'll have to pay out, and so that's why there are a lot more people who are looking at Medicare Advantage. I sat in a room with probably 15 other people, most of whom were either just approaching Medicare age or had already in it and thinking about changing. Also realizing I was the oldest person in the room, but watching different people react to that, and on a real practical and personal basis, people asking questions with regard to what their annual costs were going to be. And I think that's the biggest driver. The cost of prescription drugs is the main point of, and if you can get into a managed care program with a clear set of providers that can help reduce your overall cost, you're inclined to go there. And so I would anticipate more people going that route as opposed to fee-for-service.
That makes sense. Thank you. Our next question is, what is the chance of the United States providing a Medicare for all, and how long would it take to develop or implement?
from my perspective, first of all, disclosure, I don't support Medicare for all, and I probably should have said this in the beginning. As many of you know, a number of states in the District of Columbia operate their own state health exchanges. My wife chairs the District of Columbia Health Benefits Exchange Authority Board. Medicare for all would take some time for implementation. Think about how long it took to implement the Affordable Care Act, going back, how long it took to implement Social Security when it passed in 1935, Medicare and Medicaid when those were enacted in 1965. So if Medicare for all were enacted, that could take several years. Primarily because it would become a mandatory program, you would, as proposed, would wipe out the option of private insurance. There's no way you could sort of flip a switch and make that work. So it would have to be phased in over a period of time. Senator Elizabeth Warren, who has been a supporter of Medicare for all, you may have noticed, put out a supplemental to her proposal saying that it might take some time to implement. That's all on the basis of if it could pass. I can tell you now that even amongst Democrats, you don't have a majority of Democrats who support Medicare for all. Clearly, all Republicans oppose it. In order for that to be enacted, you'd have to have, say, either Warren or Sanders as president, and the Democrats having something like 75 seats in the Senate and maybe 300 in the House, and maybe you might have a chance of passing it. There's nothing in the tea leaves or the polls that said that that's possible. So I would anticipate that Medicare for all does not have a chance of enactment in the near future. Nikki?
Great, thank you for that. And it looks like we've exhausted some of the questions, so if you have any, go ahead and type those in. Really quickly, I'll just share with you guys an upcoming event that Colorado HFMA is promoting. It is the 22nd Annual Western Region Symposium, scheduled January 12th through the 15th at Paris Hotel in Las Vegas. So if you'd like to learn more about that, be sure to visit hfma-co.org. All right, so just doing some tap dancing there, see if we had any other questions. It looks like that we have exhausted those that have already come in, so I'll just take this opportunity to thank our members and the healthcare community for joining this call. As you exit, you will be prompted with a survey, and we would appreciate you sharing your feedback about today's event, as well as other topics you'd like to see in future webinars. So thank you again to our guest speaker, Julius Hobson, Jr. of Polsinelli PC. It is always a pleasure to work with you on these events, Julius.
Thank you very much.
And on behalf of Region 10 chapters of HFMA, thanks again for joining. Have a great afternoon, everyone.